Okay, this is going to be the urinary aspect of this lecture, and then I will separate out bowel into another one. So we're going to start with chapter 28, your urinary elimination. We know that regular elimination of liquid waste products is an essential body function, and it's critical in healthy living. We have some social, cultural, and physical requirements factor into our personal urinary elimination habits. Therefore, privacy and emotional needs, in addition to physical needs, must be addressed to ensure proper care of patients with their urinary elimination concerns. These are the chapter objectives that you can find in your F.A. Davis textbook. These are some key terms that I've pulled out. If you cannot find them in your textbook, you'll definitely be able to find them in your Tabler's dictionary. So we're going to start with the normal structure and function of the urinary system. And this would be a basic overview that you should have learned when you did anatomy and physiology. We know that nutrients from food are used by the body to maintain all organ functions, and the kidneys excrete and reabsorb water and electrolytes for the body. The urinary system controls the composition of blood by removing waste products like urea and conserving useful substances. And urea is produced when protein-rich foods are digested. The urinary system helps control your blood pressure and plays a crucial role in your electrolytes and acid-base balance, which we talked about in the last unit. So we're going to start with the A and P, and we have our kidneys. The kidneys are the major excretory organ of the body. The two kidneys are located bilaterally below your ribs towards the middle of the back. They filter liquid waste from the body, balance electrolytes in the blood, regulate blood volume and blood pressure, produce erythropoietin for red blood cell formation, synthesize vitamin D to help control your calcium levels and maintain the acid-base balance. Urine is formed by tiny filtering units called nephrons, which are the functional units of your kidneys. Each nephron consists of a renal corpuscle and a small tube, the renal tubule. The renal corpuscle is made up of a network of blood capillaries called a glomerulus, which is surrounded by the Bowman capsule. The renal tube is composed of proximal tubule, the loop of Helen, and a distal convoluted tubule. And all of this really starts to come into play more when you start talking about kidney disease and you're getting into your med surges. Still good to know now. Your urinary formation occurs as a result of three processes. So we have filtration, which initially occurs in the glomerulus. This fluid moves across the membrane as a result of pressure difference. Reabsorption occurs in the renal tubules as most of the filtrates move back into the blood. At this point, products, excess solutes, and small amounts of water are not reabsorbed but are secreted. As tubular secretion takes place, urine is produced. Urea, water, and other waste substances from urine pass through the nephrons down the renal tubules. After exiting the kidneys, urine is carried to the bladder by narrow tubes called the ureters. The ureter wall muscles continually tighten and relax, forcing urine downward. If the urine is retained in the kidney or backflows from the bladder towards the kidney, the patient can become susceptible to kidney infections. From the ureters, the urine flows into the bladder located below the umbilicus and above the symphysis pubis and the lower abdomen for storage. The bladder walls relax and expand to store urine and contract and flatten to empty urine through the urethra. Your sphincter muscles at the base of the bladder help keep the urine from leaking by closing like a tight rubber band around the opening of the bladder. The urethra transports urine from the bladder to the outside of the body for elimination and bladder emptying. The male urethra is much longer than the female, placing the female at risk for urinary tract infections. Your bladder receives a signal when it's time to urinate and empty. This impulse is referred to as urge or urgency. The brain signals the bladder muscle to tighten and the sphincter muscle to relax, which squeezes urine out of the bladder through the urethra. When all the signals occur in correct order, normal microurination or urination occurs. So microurination, which is also voiding or urinating, occurs when the contraction of the muscle pushes the stored urine through the relaxed internal urethral sphincter into the urethra. This triggers the conscious urge to void. However, voiding may be voluntarily delayed by inhibiting release of a second external urethral sphincter. When the person is ready to urinate, the brain signals the external sphincter to relax and the urine flows through the urethra. Further concentration of distress muscle normally forces out the urine remaining in the bladder. After this, the bladder will begin to fill again. And we know that a filling bladder has about 200 to 400 in it. So normal urine characteristics. Urine can be produced in small amounts or large amounts. It can be diluted or it can be concentrated. If we are dehydrated, the urine would reduce and the elimination of the waste would make it more concentrated. Normal urine is considered sterile. Urine contains fluids, salts, waste products, and is free of bacteria, viruses, and fungi. The amount of urine that an adult passes per day is dependent on the amount of fluids consumed, as well as medications, medical conditions, dietary intake, like salt. During the night, urine formation decreases to approximately half of what it is during the day. Your normal production of urine is around 50 to 60 mLs an hour. And typically we void at 200 to 400 mLs. And some people can hold a liter or more. So factors affecting your urinary elimination can be related to diversity, pathological or non-pathological factors. Your diversity considerations encompass your lifespan, your age, your pregnancy, your gender, culture, disability, and morphology. So starting with the lifespan, we remember that infant and children will produce less urine and will have to develop controlled over urination. We talked about toilet training. Toilet training can be 18 to 36 months. However, we know that school-age children can still develop enuresis, which is entirely normal for those school-age children because they become so involved in a game that they don't realize they have to go, and then they have an accident. We can also have nocturnal uresis, which would be that nighttime bedwetting. For our older patients, we have a lot of things that can impact. So we have the renal blood flow, which progressively decreases with aging, primary because the changes to the micro blood vessels to the kidney. This decline in glomerular filtration is the most important functional deficit caused by aging. And the potential volume of the bladder decreases because we have a loss of elasticity in the bladder wall. Thus, the older adult needs to urinate more frequently. Pregnancy. During pregnancy, the growing fetus compromises the bladder space and compresses the bladder. 30 to 50% increase in circulating volume occurs during pregnancy, which increases the renal workload. You can also have gender issues, so an enlargement of a prostate in men 40 years plus and older may lead to urinary frequency, hesitancy, and retention. Urinary tract infections are more prevalent in females because of the shorter urethra and because women experience a decrease in pelvic area muscle tone with age and childbirth. Cultural concerns. Studies indicate that minority women are less likely to seek professional help to treat a urinary tract infection than women of Western cultures. In some cultures, it's considered inappropriate for a member of the opposite sex to care for a patient. Nurses should develop care plans to reflect cultural sensitivity to the needs of the patient and their family. Our immigrants face tremendous obstacles to seeking treatment for urinary concerns, including language and cultural barriers, as well as lack of health insurance. Disability. A total or partial disability may lead to urinary incontinence or retention. Our paraplegics can be taught to empty the bladder using straight catheterization to avoid urinary retention, which could lead to them having urinary tract infections. A lack of privacy in hospitals and assisted care facilities can contribute to incontinence or retention, as well as insufficient time taken to void can lead to changes in your urinary elimination patterns. Morphology. Our obese patients will have an increased pressure on the abdomen as they're lying down, and this can lead to inadequate bladder emptying. And also constipation can compress the urethra, not allowing the urine to empty. So our pathological and non-pathological factors. So your non-pathological factors are going to be things that are not related to the pathology of your human anatomy. So personal would be anxiety. So patients that are anxious about a lack of time to go, a lack of privacy to go, loss of dignity can affect your ability. Sociocultural, some patients will state personal, cultural, or religious requirements for toileting. We just talked about nutrition. Substances that contain caffeine, such as coffee, tea, cola, and chocolate, can all act as a diuretic and increase your urine production. Consuming large amounts of alcohol impairs the release of antidiuretic hormone, resulting in an increased production of urine. In contrast, a diet high in salt can cause retention and can decrease your urine production. Hydration. The kidneys also spare water when a person is dehydrated, such as after heavy exercise or when fluid intake is inadequate. This causes the urine to become concentrated and low in volume. During prolonged periods of physical activity, especially in hot weather, the body loses sodium and other electrolytes rapidly through sweat. For this reason, electrolyte replacement beverages may be more beneficial than plain water to help preventing dehydration. Or medications. If we're giving a patient a diuretic, it will cause them to have an increased urine output. Remember, a loop diuretic like furosemide will also reduce their potassium levels. We have some anticholinergic medications, which are given to relieve bladder spasms. However, it can cause urinary retention and inhibit the free flow of the urine. Also have drugs that are nephrotoxic, like some antibiotics. An example would be gentamicin, where high doses or long-time use can cause damage. And your non-steroidal anti-inflammatories, like aspirin and ibuprofen, can also cause kidney damage. And the last one that we'll mention in this section would be the effects of surgery and anesthesia. Surgery can have various effects on your urinary tract. Anesthetic agents can decrease blood pressure and glomerular filtration, thus decreasing urine formation. And then we have spinal anesthesia, which can decrease the patient's awareness of the need to void, which can lead to bladder distension. Your pathological factors. These are going to be those physical things. So pathological condition, disorders of the urinary system that affect urinary elimination include infection or inflammation of the bladder, ureters, the kidneys, renal calculi, which would be a kidney stone, tumors, which can obstruct the normal flow of the urine, and prostate, which would affect the flow of the urine in older men. We can also have hypertrophy, which is the excessive growth of the prostate. It can be benign or it can be cancerous. We can have cardiovascular and metabolic disorders that can decrease the blood flow through the glomeruli and thus impair the filtration. Any condition that affects the nervous system control of the urinary system organ can impair the urinary elimination. So after a stroke, a spinal cord injury, for example, a patient may lose bladder control. We have immobility, and impaired communication, which can interfere with the ability to get to the bathroom in time or to communicate the need for assistance. This may result in urination in an inappropriate setting or at an inappropriate time. And then cognitive changes, right, that alter the perception of the urge to avoid, or a severe psychiatric condition involving altered perception or ability to manage activities of daily living may also lead to incontinence. So our types of abnormal urinary patterns, so we have anuria, which is the failure of the kidneys to produce and excrete urine. Anuria occurs as a result of a process that limits effective blood flow through the kidneys. We have oliguria, which is defined as a reduced urine volume. This is less than 0.5 mLs a kilogram an hour in children or adults, or less than 500 mLs a day. This oliguria is a symptom of chronic or acute renal failure, which can be classified as pre-renal, renal, or post-renal, but you'll get into that when you get into acute conditions in med-surg 2. You can have polyuria, which is an excessive volume of urine, and it's going to be over 2,500 mLs a day of urine or greater. You can have nocturia, which is an excessive urination at night. This will affect the patient to awaken several times during the night to urinate. It can disrupt their sleep cycle. Most people should be able to sleep 6 to 8 hours without urinating. We can have dysuria, which is painful urination. Dysuria can occur from a number of factors, such as a bladder infection, cystitis, sexually transmitted diseases, yeast infections, kidney bladder stones, certain contraceptive foams, sponges, tampons, toilet papers, spermicides. Many things can cause you to have dysuria. Then hematuria is the abnormal presence of red blood cells. We can have microscopic hematuria, which means the only way you're going to see it is if it's under a microscope, or you can have macroscopic, which you're going to be able to see just by looking at the cup. We can have urinary incontinence, which is the inability to control the passage of urine, and we'll discuss that more in a few slides. And we can have urine retention, right? And this is the inability of the bladder to empty. It can be caused by an obstruction of the urinary tract from, let's say, an enlarged prostate, or from a neurological disorder. So we're going to go into the nursing process now. This is going to be your ADPI for your urinary symptoms, and we're going to start with assessment. So what assessments and cues are we going to want to look at when we're talking about assessing the urine? So to assess a urinary elimination, we will use data from the nursing history, physical exam, diagnostic and laboratory reports. Many diagnostic procedures of the urinary tract are performed in the operating room, procedure suites, and the radiological departments. Typically, nurses prepare the patient for the procedure, assist with specimen collection, deliver aftercare, and sometimes assist the physician. We're going to want to make sure that we're measuring their input and their outtake. So whatever they're outputting or intaking, we want to record all fluids the patient drinks or receives via intravenously. And then any fluid that's lost. So our lost fluid can be from urine output. It can be gastrointestinal loss, such as diarrhea, or for emesis, if they're vomiting. We want to know the quantity of the fluids that the patient's drinking and urinating. These are some questions that you might ask a patient to help you focus on your urinary assessment. This is how we're going to actually do the abdominal inspection. So remember, we're always going to inspect first. We're going to be looking at our skin color, the contour, the symmetry, if it's distended while the patient's in that supine lying position. Normally the abdomen's not distended and it's symmetrical, and it should be free of bruise, masses, and swelling. A distended bladder may be visible in the suprapubic area if you have a very frail or thin patient. A bladder scan can be used by the nurse to see if the bladder is holding urine. However, abdominal distension can be caused from other conditions like we've talked about with like ascites. We can auscultate the left and right renal arteries. Normally sound should not be heard. And you wouldn't obviously auscultate the bladder because you're not going to hear anything there. We can do palpation of the bladder, which is conducted to determine if it is distended. Typically, you're only going to be able to feel the bladder if it is full. And then percussion, not typically used by an associate or floor nurse. That's going to be more your advanced practice nurse. But if your bladder is full or distended, they can use percussion to actually hear it. So your inspection of the urine, right? We're going to want to know what the color is. Your normal urine color can range from a pale yellow to an amber. Common causes of urine discoloration can be medications, foods, food dyes. Urine color can also be altered by certain health problems. A concentrated urine from dehydration is going to be a darker amber in color. A urine that's diluted, which would be clear and pale, could be due to excessive fluid intake or because the kidneys are having issues concentrating the urine. We can have red or pink urine, which can be associated with bleeding, urinary tract infections, or from foods. So foods like beets, blackberries, and rhubarb can cause your urine to be pink or red. Carrots, carrot juice, and certain medications contain orange. Brown or tea-colored urine is associated with consumption of fava beans and aloe vera. Asparagus consumption can sometimes turn urine green. Medications, as I said, can also affect the color of your urine. Rifampin, warfarin can turn your urine orange in color. Blue can be seen in propofol. We have pathological conditions. So patients with hypercalcemia, that high calcium, can have blue-green urine. People with liver failure from hepatitis or cirrhosis can have brown or tea-colored. Severe dehydration can cause urine to change between a dark yellow orange all the way to tea color. Clarity, urine normally is clear. If it's cloudy, it could be the presence of bacteria, blood, sperm, crystals, mucus. After bladder or kidney surgery, patients may excrete blood, urine containing clots. This typically requires irrigation. The odor of your urine, normal urine usually does not smell very strong. If we're dehydrated, it may increase the odor of the urine as more waste is excreted in smaller volume. Food, most notably asparagus, can definitely cause for an odor to your urine. If you're somebody with uncontrolled diabetes, the urine could have a sweet, fruity odor. Whereas if they have that infection, they're going to have a strong, unpleasant odor. Just like a wound that's infected would have that strong, unpleasant odor. And then we want to assess the amount, right? The amount of urine that the patient eliminates can vary depending on factors of their fluid intake, their dehydration, if they're retaining, medications they take. So the diagnostic tests, what diagnostic tests are you going to be reviewing? So you're going to want to look at your lab. Common tests to be evaluated in urinary function include the measurements of the BUN, the serum creatinine. We can do urinalysis, urine cultures, and we're going to talk about that stuff here. So your BUN and your creatinine level will become elevated, particularly if you're having renal impairment. BUN concentration is measure of the urea level in the blood. Urea is cleared by the kidney, and the levels may increase if a patient is dehydrated or has a disease compromise that is affecting the function of the kidney. Normal values for BUN in the blood are 7 to 20. If they're elevated, kidney injury, disease, conditions such as diabetes, high blood pressure, blockage of the urinary tract, high protein diet, severe burns can all affect your BUN level. If your patients have a low BUN value, this can be caused when a patient has excessive fluid intake. And then creatinine is filtered along with other waste products from the blood by the kidney and eliminated in the urine. It's made at a steady rate, and levels are not affected by a diet or normal physical activity. The patient with kidney damage may decrease urinary creatinine, but increase serum levels. The amount of the creatinine in the blood is directly related to the muscle mass. Generally, creatinine levels are higher in men than in women. Your normal serum creatinine is 0.6 to 1.2 for women and 0.8 to 1.4 for men. And again, if the BUN and the serum creatinine are elevated, this is a concern for renal or kidney failure. So when we're looking at our urinalysis and we want to know what those numbers mean, your urinalysis is an assessment of the urine at a single point in time. The urinalysis is a good screening tool for a urinary tract infection, kidney disease, and some other conditions. The single sample can be used to detect the measurement of bacteria, glucose, white blood cells, red blood cells, proteins, and other substances. Urinalysis samples are collected by having the patient void into a specimen cup or samples by taking a catheterization sample. We usually only need about 10 to 15 cc's. Your urine specific gravity monitors the balance of waste and solutes. Your normal gravity is 1.002 to 1.03. The higher the level of the specific gravity, the more solid material is contained in the urine. Fluid intake has a direct relationship to your urine specific gravity. If we have large volumes of water consumed, we're going to dilute it and produce a lower specific gravity than if we have less. So a urine specific gravity is going to be high in conditions of dehydration. Your pH. So this is different than the pH that we learned when we were doing fluids and electrolytes. This is specifically the pH of your urine. The acid-base balance in the body is determined by the pH, which reflects the acidity or the alkalinity of the urine. The urine normally is slightly acidic with the average pH of 6. Urine pH that is 4 is considered very acidic, and a pH of 7 is neutral, and a pH of 9 is very alkaline. The pH is useful in determining kidneys' response to acid-base imbalances. In metabolic acidosis, the urine pH decreases as the kidneys excrete hydrogen. Maintaining a healthy pH helps prevent the formation of kidney stones. Urine for protein. Normally, urine does not contain protein. Protein modules generally are too large to escape from the glomerulus capillaries into filtrate. Proteins in the urine may be associated with fever, vigorous exercise, pregnancy, and some diseases such as kidneys. In conditions such as glomerular nephritis, the cell membranes can become permeable and allow those proteins to cross. Glucose. Normal urine contains very little to no glucose. The urine glucose concentration is used to screen for diabetes and to assess glucose tolerance. Glucose in the urine may be a sign of kidney damage or disease. Urine glucose levels are not an adequate measure of blood glucose levels. In uncontrolled diabetic patient, glucose may appear in the urine. Ketones, the presence of ketones in the urine, which is ketonuria, indicates that fat has broken down from energy. Ketones are normally not passed into the urine. Large amounts of ketones in the urine may indicate diabetic ketoacidosis. A diet low in sugars and carbohydrates, prolonged fasting or starvation, and vomiting can also be associated with ketonuria. Microscopic analysis. For microscopic analysis, urine is spun in a centrifuge and sediment settles at the bottom. The sediment is then spread on a slide and checked for blood cells, casts, bugs, and crystals. The presence of crystals in the urine may indicate that stones are present. Bacteria, yeast, and parasites are not present in urine, but when they are, that would be an infection. Suspected urinary tract infection is when we check the urine and we're positive for nitrates. Nitrate levels increase when bacteria are present. A leukocyte esterase test determines the level of white blood cells in the urine. Elevated levels can also indicate a urinary tract infection. Culture and sensitivity. Your urine culture and sensitivity testing are performed for a diagnosis of a urinary tract infection. Urine in the bladder normally is sterile. It does not contain bacteria or organisms. If an organism grows in the culture and sensitivity, testing is then performed to determine the appropriate antibiotic to treat the patient. Our 24-hour urine collection. So your 24-hour urine collection is commonly performed to determine the amount of creatinine clearance. This time specimen can also be used to measure levels of protein, hormones, minerals, and other chemical compounds in the urine. The creatinine clearance, which measures how well the creatinine is moved from the body and the kidneys, provides information about the kidney function. Factors or conditions that may interfere with accuracy of 24-hour urine collection include failure to include some portion of the urine output, continuing the collection beyond 24 hours, spilling the specimen, inability to keep the specimen cool, and previous ingestion of certain foods or medication. Preparation is not required before the initiation of a 24-hour urine collection. The best time to start the patient's first morning void is our best time, and the first morning voided specimen is not saved. All the urine produced after the first urine, and then we collect until the next morning's first urine. If the sample becomes too warm, if we miss one, we have to discard the entire sample and start again the next day. Additional tests. So we can do an ultrasound, and the ultrasound scan is going to help to assess the size, shape, location of the kidneys, the bladder. Blood flow can be used. This image here is a bladder scanner, which will allow you to scan the patient's abdomen and see if the patient is retaining urine or has urine in their bladder. We can do X-ray studies. So we have a test called a KUB, which is going to give you your kidneys, your ureter, and your bladder. The study is a diagnostic X-ray image centered on the iliac crest, typically used to investigate gastrointestinal conditions, but it can also detect the presence of kidney stones. In addition, KUB studies are used to assess positioning of indwelling devices, like if your patient has a ureteral stent, and stents can be placed to prevent or treat obstructions. We also can do an intravenous pylography. So the intravenous pyelogram is going to be an X-ray study of the kidneys, the bladders, the ureters, and the urethra. The images will show the size, shape, and positions of the urinary tract. The procedure involves the injection of contrast material into the vein. X-ray images are then taken at time intervals. This IVP commonly is performed to identify kidney stones, tumors, or infections. Contraindications is if the patient is pregnant, has severe kidney disease, or has taken metformin within 48 hours. If the patient has an allergy to iodine, would be another contrast. You need to assess your patient for an allergy to iodine before that they go. And we need to make sure that we keep our patients hydrated after the test so that we flush out any contrast medium that could be left in. So key takeaways, if your patient's having any type of intravenous pyelogram or pyelography, we want to assess them to make sure that they're not going to have a reaction to the contrast dye. And then we're going to want to make sure that we hydrate them afterwards to flush out the dye. We can have CAT scans, so computed tomography, which is a CT, can be used to diagnose kidney stones, bladder stones, or blockages of the urinary tract. Contrast medium may be used during the procedure to help identify blockages, growths, infections, or other diseases. Patient may be required to be nothing by mouth beforehand. Cystoscopy is an examination of the bladder and the urethra. This is when they're going to pass the camera through the urethra into the bladder. This is typically performed under general anesthesia. However, they can do a local or a spinal. And the patient needs to be nothing by mouth 8 to 12 hours before the test. The entire examination can take up to 45 minutes. The patient may experience a burning sensation and an urge to urinate during the procedure. Lying on the table can be very uncomfortable. Risks associated with this test are those things of anesthesia, as well as the patient can have difficulty urinating and pain afterwards. They should not develop a urinary tract infection afterwards, but it can happen. And they can have pink tinged urine several days after it, particularly if they do a biopsy during the scope. So now that we've gone through all the things that we want to assess, we're going to be looking at what type of nursing diagnosis or nursing concepts that we're going to use. So if we have somebody who are worried that they're going to develop a urinary tract infection, or are they having a problems eliminating their urine, whether they're unable to eliminate or are they incontinent in their elimination. So we're going to plan, right? We chose one of those, now it's time to plan. Your overall planning and outcomes is you are going to want to optimize their kidney function. You're going to want to optimize their urinary elimination. You're going to want to have good tissue integrity, because we know that if urine's laying on the skin, they can have that maceration and then their skin can break down. And we want to, reduce urinary incontinence. So what interventions can we do? How can we care for these patients? So first thing that we want to do is we want to promote normal urination. So providing privacy is very important. Although urination is a normal process, most people consider it to be a very private matter. Taking a matter-of-fact approach confirms the patient that you're comfortable with this aspect of care, but we still want to provide privacy when discussing and providing care related to urination. We want to excuse visitors from the room, draw a dividing curtain if necessary. We might have to assist the patient to a private bathroom. Assisting them with position. So remember, most men stand to void and they may have difficulties voiding in other positions. Whenever possible, we want to assist the patient to the bathroom to use the toilet and allow them to assume their preferred position. Women generally find an upright seated or squatting position to be most comfortable in voiding. If a female patient must remain in the bed, we can provide her with a bed plan, placing her in a high semi-Fowler's position to urinate unless that's contraindicated. We do have urinals for both males and females that can be urinated. We definitely want to facilitate toilet routines. Most patients void on awakening, after meals, after drinking large volumes of fluid, before bedtime. Some might go during the night. So we need to identify your patient's pattern and try to stick to it as much as possible. If you anticipate a change in the pattern for elimination, inform your patient. So if we critically think that we gave our patient an IV diuretic, that diuretic is going to start to take effect quickly. So we would educate our patient, I'm giving you this diuretic, it's going to make you pee, and then discuss your toileting plan of care for them. We want to promote adequate fluids and nutrition. Adequate hydration promotes healthy urine function and flushes the system of waste products. Most people should drink 8 to 10 glasses of 8 ounces of fluid daily unless health problems limit their fluid intake. Many people do not meet the recommended intake. Water is your preferred fluid, because things that are caffeinated can cause diuresis, which can further promote incontinence. And we want to assist them with hygiene, right? Urine is irritating to the skin, therefore the perineal needs cleansing. It's going to be an essential part of toileting hygiene. It may include pouring warm soapy water over the genitals while the patient is seated on the toilet or bedside commode or bedpan. We need to rinse with warm water because soap is drying to the genital mucosa. Also, for a moist washcloth or towelette, and make sure that we dry because we don't want to leave moisture down there. So causes of our alterations in urinary elimination, right? What can stop us from being able to pee? A urinary tract infection, right? E. coli is the most common cause of your urinary tract infections, and that typically comes from the stool getting into the urinary tract. We can also have urethritis, which is an infection limited just to the urethra. And we can have cystitis, which occurs when the bacteria travels up the bladder up the urethra into the bladder, causing a bladder infection. If it's not treated promptly, the infection may progress into a kidney infection because it'll travel from the bladder up the ureters and get into there. We can have urinary retention. So urinary retention is the inability to empty the bladder. Etiologies can be obstructions, inflammations, swellings, neurological problems, medications, anesthesia, and anxiety. We can have urinary incontinence, which would be the lack of voluntary control over urination. Urinary incontinence we'll discuss further on the next slide. We can have urinary diversion, which when your patient's going to have a urostomy, something that's surgically created, opening for elimination of urine. And we'll discuss those in a little bit too. So our urinary incontinence, right? Incontinence is the inability to control the passage of urine. We can have stress incontinence, which is the loss of urine control during activities. So if your patient has coughing, sneezing, laughing, exercises, anything that increases the intra-abdominal pressure and they urinate, that would be stress incontinence. Urge incontinence involves a sudden, strong urge to void, followed by rapid bladder contraction. The affected person does not have enough time for toileting between recognition of the urge to urinate and the onset of voiding. Mixed incontinence is a combination of stress and urge. Functional incontinence refers to a lack of control and the absence of any abnormalities of the urinary tract. It occurs when some physical limitation in functioning, such as difficulty with closing fasteners or impaired mobility, hinders reaching the toilet before void. Many of your patients in the hospital will have functional incontinence because they can't find the call bell in time to hit the call bell, have somebody come in and assist them to the toilet. So they'll exhibit functional incontinence. Overflow incontinence is seen in patients who are unable to empty their bladder completely, resulting in a constant dribbling of urine or increased frequency of urination. Overflow incontinence results from weakened muscles of the bladder, which may be a consequence of certain pathological conditions, like an enlarged prostate. We see a lot of overflow incontinence with that. Temporary incontinence can occur in association with factors such as severe constipation, infections of the urinary tract, or medication use. This urinary incontinence is often seen in your elderly people, although not all elderly will become incontinent and will become fixed when we deal with the underlying problem. So managing urinary retention, what are we going to do if we have a patient who's rotating? So first we're going to monitor, right? We're going to assess the distended bladder. We're going to use our bladder scanner and figure out how much urine is in the bladder. We're going to encourage our patient to void. And then after they void, we're going to do another bladder scanner to see what their post-void residual is. At that point, if they're still having a full bladder, we could do a straight cath, which is going to be a single lumen tube that's inserted for the immediate drainage of the bladder. After the bladder is empty, a sample is obtained, the catheter is removed, and the patient should resume voiding independently. Straight caths are typical if we have somebody who's having urinary retention due to anesthesia. Then once that anesthesia wears off, they'll be able to void again. If we're having somebody who's having like a prostate or some type of obstructional issue that's not going to be relieved, then we might do an indwelling catheter. So this would be your Foley catheter. So this is when we're going to need a continuous drainage. and we're going to insert it, and then we're going to connect it to the bag, and we're going to make sure that it's a secured device is used. And then a suprapubic catheter is also a continuous drain, and that's going to be on their abdominal area. It's going to go from their suprapubic area directly into their bladder, and it's going to pass the urethra completely. So your patient's teaching. What are we going to teach our patient? To aid them in emptying their bladder. So we want to place the patient in a flat Fowler's position, a position of bedpan and urinal, if we need that. If we can assist our male patient to stand, if possible, that will be helpful. Reed's method is placing our hand on the flat of the patient's abdomen, just below the umbilicus. And we'll ask the patient to kind of bend forward, and then we're going to firmly start downward on the bladder, and hopefully that will help stimulate the voiding reflex. We can also strengthen the pelvic floor muscles by doing Kegels, and that's going to be for your female patients to improve tone and increase the control of the flow of the urine. And we want the nurse to also teach patients to call their healthcare professional if they're starting to have the inability to urinate, if they develop an intense pain in their lower abdomen or the urinary tract, if they start having fever, vomiting, side back pain, chills, passing some just tiny bits of urine for a few days. If they develop blood in the urine, cloudy, foul smelling urine, if they're experiencing frequency and urgency, or if they have discharge coming out of their penis or vaginal area. So a little bit more on our Foley catheters, right? We know that Foley catheters are the leading cause of healthcare associated infections, also known as your nosocomial infections. We want to make sure that we check for allergies, because if some of our catheters have betadine in it, which patients can be allergic to, and some catheters still contain latex. This is a sterile procedure. We want to make sure that we explain to the patient the reason that the catheter is being inserted, the expected length of time the catheter will be needed, and the sensations that they're likely to have. Most patients experience a sensation of pressure and some discomfort. It should not be painful when the catheter is inserted. However, if there's swelling or bleeding in the urinary tract, insertion can be painful. And typically, if there's blood at the meatus, that's a contraindication for a nurse to place a catheter. We want to explain when the catheter is inserted that it may feel as if they're voiding, but the urine's going to be in the tube, not into the bed. Again, we want to use that dorsal recumbent position for the female and a supine position for our men. For female patients, we want to make sure to lower this section of the bed, and then our knees are going to be elevated and relaxed to our sides. If your woman's unable to tolerate that dorsal recumbent position, we can also consider a Sims or a lateral position. We want to make sure that before we open our sterile field, that we make sure that the meatus and the perineum area is clean. And then we want to make sure that we wash our hands prior to opening up that sterile field again. Our goals for nursing care with a patient with an indwelling catheter is to prevent them from having any urinary tract infections. We want to make sure that we maintain a free flow of urine and that the urinary drainage bag is below the level of the bladder. We want to prevent transmission of infections and promote normal urine production. And we want to maintain that skin mucosal integrity. So we definitely want to make sure that we use some type of stabilization device, whether you have this stat lock or a different manufacturer. The stabilization device is very important because it stops traction on the bladder and the meatus. When we're managing urinary incontinence is no longer a reason to put a Foley catheter in. We want to make sure to prevent skin breakdown. We remember that normal urine is acidic, and when it remains in contact with the skin, it can cause dermatitis and skin excoriation. It's essential to keep the skin, clothing, and bedding clean and dry, especially after leakage of urine. We can use barrier creams for irritated skin. Antifungals may need to be prescribed, like nystatin, to prevent or eliminate fungus growth. Lifestyle modifications, they might need to increase fluid intake, they might need to reduce fluid intake, they might need to avoid caffeine. Weight reduction can help. As little as 5 to 10% alleviates incontinence symptoms and improves the quality of life in patients. We can do bladder training. The goal of bladder training is to enable the patient to hold increasingly greater volumes. We typically start at 2 hours and move up. And then again, the Kegel exercises are most commonly used method for preventing and reversing incontinence in the woman for the first year after giving birth. So strategies to promote independent urination. We have pharmacological interventions such as estrogen may be prescribed for postmenopausal women who are having incontinence secondary to atrophy of their vaginitis. We can have medications for urgent incontinence. Medications may be used to relax and increase the bladder's capacity. We can have surgical interventions when incontinence is caused by things like an enlarged prostate. And we make sure that we always do parent teaching for that enuresis. And again, children may be embarrassed if they're having this. So we just need to make sure that we educate the patients and their families what's normal and how they can prevent that from happening. They may need to schedule regular trips to the bathroom and watch for nonverbal cues for their kids. So the urinary diversions, right? A urinary diversion or urostomy is a surgically created opening for the elimination of urine. The patient with a urinary diversion does not eliminate urine via the urethra. Instead, the urine bypasses the bladder and is expelled through a stoma or an ostomy. There's typically 4 types. You can have cutaneous urostomy, and this surgery reroutes the ureters directly to the surface of the abdomen, forming a small stoma. We can have a conventional urostomy, which is an ileoconduit, and this is the most common type of urinary diversion because it's the simplest to perform surgically and eliminates the need for intermittent catheterization. The ureters are implanted into a loop of ileum, which would be the small intestine, where the urine drains freely into a stoma bag. The downside is urine can come back up into the kidneys, causing an infection, and they can develop stone formation. We can have a continent urinary reservoir, which would be a pouch. And this continent urinary reserve is similar to the ileoconduit, except urine drains into a pouch that's made from a portion of the intestine. And we have a stoma on the abdomen, and the patient will have to self-cath there. Or they may have a valve present, and the valve would need to be open to drain. And then we can have that neobladder, and a neobladder will mimic the function of a urinary bladder. And this is a portion of the intestine is made into a pouch or a reservoir that's connected to the urethra. Urine passes through the urethra similar to the normal passage of urine. The patient voids by bearing down and applying pressure over the bladder using that Creday's method maneuver. But they may also need to perform intermittent self-catheterizations to fully empty their bladder. Your interprofessional collaboration and things that you can delegate regarding this. So our unlicensed personnel, like the nurses' aides, remember they can assist your patient and they can give you the amount that your patient has void. However, when it comes to assessing the color or any assessment things, you, the primary nurse, have to do that. You might have a nurse continence specialist on the floor that can help your patient with those Kegel pelvic floor exercises. You may have a physical therapist that can help design a plan to increase your patient's overall muscle strength. Depending on the physical limitations, the family may need to alter their home environment to accommodate the patient's elimination needs. So if they live in a 2-story house and only bathrooms upstairs, that's going to dramatically impact that patient's ability to have appropriate urination time. And in some settings, your nurse's aide may be permitted to insert a urinary catheter, but this is not routine practice. This is not something that Tennessee, from what I've realized, has done. However, the unlicensed person can assist with positioning the patient, focusing the light so that you can see your urethra better, providing some comfort measures for your patient when you're performing the procedure. And that is the end of the urinary workshop.